And the second hype and the last presentation will be Professor Scott Melvin. Please.
Thank you. We're using the mouse or the cue. Thank you very much. I appreciate the previous two orders. I too am excited about the future of robotics and what might happen and could happen in the years coming forward. However, today's talk is really relegated to what reality is, the reality that we are faced with the current status of robotic surgery. My kids are in high school, and I help them with their persuasive speech and their speech writing classes. And when we want to subject someone to our persuasion, we really want to present facts and objective data to make a convincing argument. You want significant subjective or emotional arguments, or you want skilled orators and impassioned champions. Fortunately, I face none of those obstacles today. There are 3 points that I'd like to make. One is that this is not new technology, as we've seen demonstrated. There is no data for superiority using current instruments, and that we do, in fact, have prohibitive cost. Much like the other pictures that we saw, this is an operating room of the past, perhaps of the current in some situations. And robotic surgery with the Da Vinci was launched more than a decade ago at the World Congress of Endoscopic Surgery. The age of robots really came out, the front page of magazines, the age of robots in 1999. Much like the value and the changes that we saw in vehicle transportation. It was a nice 5 minutes video about a car that's irrelevant, but nonetheless. And so we've seen some changes. What are the changes that we've seen in the robot since 1999? Well, let's look at some of the other changes. BlackBerry was introduced in 1999, as well as the Pentium 3 500 megahertz processor. Internet Explorer 5, WikiWeb was adopted, and the first microdrive was available. Now, both with the scale of economy, things have changed somewhat. The Apple iPhone 4S, the Apple iPad 3, an Intel Core processor with 2.5 gigahertz processor off the shelf for sale in Walmart, Internet Explorer 9.0, and 32 gigs of memory for $29 you can carry in your pocket. And so we're back to the robot in 2012. So we've seen a significant change in technology and our abilities, but relatively the same stable, large platform in our operating rooms. But yet we've seen an increase in annual worldwide procedures done with the Da Vinci, a significant number of increased in instrumentations throughout the world, and the number of installations in the United States continues to expand dramatically. Now, why is this? In general surgery, we've seen huge growth. In gynecological and colorectal surgery, we've seen huge growth of the device. But do we know why this is? Today's call is really evidence-based medicine. It's not too difficult to go out and find the evidence-based medicine toolkit, finding evidence for practice, writing guidelines. SAGES, in fact, is an organization that has many guidelines, that routinely writes guidelines based on evidence for new technology, for safe clinical practice, for appropriate clinical practice. So in 1999, the evidence-based guidelines for robotic surgery were this, a blank page. Now in 2012, the evidence-based guidelines for robotic surgery is this, a blank page. Evidence for robotic surgical interventions to improve outcomes, a blank page. Robotic surgery at its current state is used pretty widely. There's new technology, there's perhaps general surgery applications, and I'm excited about the new technology and directions. Mark and my other authors presented some of the early cases. This was published in 2002. A variety of general surgery cases could easily be accomplished. Our conclusions were that there were no major complications related to the device. Hoopla. Heller myotomy, as we pointed out earlier, 100 clinical cases. There was no perforation. We were able to achieve similar clinical outcomes were our conclusions. However, in reality, we compared cases done by experienced attending surgeons, keeping our residents and fellows perhaps away from those patients, but a very high volume attending surgeons. This was not an inferiority study. This is what it should look like at the end of the case. A variety of advanced procedures have been proposed in general surgery and GI surgery specifically for this talk. Robotic surgery for pancreas resection, been around more than a decade. Certainly, there's a lot of different data that's been published, but basically the conclusions are that it's safe, it's feasible, and early outcomes are similar to open surgery. Earlier, Dr. Talamini showed us that many of the conclusions were that it was at least similar to laparoscopic surgery, with the exception that it took longer and cost more. This recent publication of pancreaticoduodenectomy, an amazing 512 minutes and 9 hospital days to develop robotic pancreatectomy. Conclusion, sounds like a safe, appropriate operation. No wonder you need such good economics if it takes so long to sit there. How about robotic esophageal surgery? This systematic review was published last year. No randomized clinical trials. 2 relatively poorly matched control trials. They were case series or expert opinion. Overall, there was no difference in oncological preferences, and there may have been some benefits compared to open surgery. Robotic liver surgery, clearly feasible, perhaps safe for minimally invasive liver surgery. Multiple trials in robotic bariatric surgery. The systematic review showed over 300 reports. Only 22 included reasonable data, but a large number of patients. There were no deaths. There were few complications and leaks that were similar to laparoscopic surgery. Once again, concluding that feasibility and it was safe. The same for robotic colon surgery, a primary growth market, feasible and as safe as laparoscopic surgery. Let's look at the value. Earlier we heard it cost $2.2 million. Suppose you had a bargain rate, $1.5 million flat out. What does that equal in American healthcare society? About 5,000 screening colonoscopies, saving lives because preventing colon cancer. 80,000 vaccines to prevent hepatitis B. 20,000 vaccines to prevent HPV that can cause cervical cancer and oral cancer, and the like. Or perhaps 3 real information system rooms in your operating rooms, integrated information MIS rooms instead of the robot. So what's next in general surgery with robotics? I hope we see the continued evolution of robotic devices to help improve our ability to take care of patients. Procedure and product development is important. Our goal should be to define the place for robots and utilize the latest technology to help our patients. I hope we have new technology. I hope we can help patients. I hope we can pay for this technology. But at least we need to hope for data that steers us in the right direction. However, the reality is that laparoscopic technology is really, really good. There is hope for laparoscopy still. Laparoscopic skills have advanced in the last decade. There's few barriers to laparoscopic surgery. And as a surgeon, what would you want? We're smart. Would you want a fully integrated endosuite that you and your partners could work in every day, or one robot in your rooms? Now, Mark said earlier, if you give us better tools, we'll do better operations. I like Mark, and I believe a lot of the things that you said, and that's a really nice sentiment. But we're smart people. In a decade, we can't develop instruments that are subtle enough to see what those objective outcomes are. Perhaps our measurements aren't good enough, but perhaps we just don't have a tool that can really help us yet as far as robotic surgery goes. We continue to accumulate data that looks at the use of robotics in general surgery. It's clear that the logistics and OR room efficiency might be overshadowed, but it's okay if it has proven patient benefits or surgeon benefits. The current platforms and devices and technique remain under development. We await further development. There are few prospective data of robotic procedures that document superiority, and while the objective data is accumulating, most we can hope for is similarity. Technology is expensive. Spend your money wisely. The hope for robotic surgery continues. Today, it's hype. Thank you.